Good afternoon. I am going to present the mysterious case of traumatic anterior chamber fistula, a Blepp's tail. Ocular trauma is a significant cause of visual morbidity in pediatric patients, often leading to long-term complications if not promptly diagnosed and managed. Retained IOFP are a potential consequence of ocular injuries and may remain undetected, especially in cases with subtle or atypical presentations. My case is a four-year-old boy presented with swelling in white part of the right eye for 2 months, which progressively increased to the present state. There is a history of trauma with pen while playing with brother 8 months ago, for which previous consultation was done only for redness. On presentation, the best corrected visual acuity was 6/24 in right eye with a pressure of 6 mm of mercury, whereas in left eye it was 6/6. On conjunctiva, we could appreciate a bleb which is present at 5 o'clock, 1 millimeter away from the limbus, about 1 into 1 mm size, with a central pigmentation, query foreign body. The AC was formed deep, and we could see the bleb. The rest anterior segment finding was within normal limit. And right eye on fundus examination, we could appreciate that the disc margin are blurred with chorioretinal folds were seen in the fundus. In the left eye, the fundus was within normal limit. So based on our clinical history, we came to a provisional diagnosis of a foreign body in situ forming a bleb causing hypertensive maculopathy. On investigation, we found that NCCT head with orbit, there was no abnormality seen, that is no foreign body was present. On multicolor imaging, we could appreciate the chorioretinal fold, and on OCT disc, we could see the disc edema is present in the right eye. On anterior segment AIOS OCT, we could appreciate the bleb is formed beneath the limbus, and we could see the scleral integrity is also not there. So we took the patient for intra-op wound exploration with scleral tear repair. We found that there was no foreign body in situ as such, but there was iris incarcerated, which was acting as a sit-on, like a sit-on, forming a conjunctival bleb, which was further causing the hypertensive maculopathy. So we did a wound exploration, and gonioscopy was also performed to see if anything is present in the angles, and then scleral tear repair was done. This is the intra-op video where we can see that on injecting the dye, when we inject the trypan blue, we can see it is coming from the other side where the perforation was present, suggesting that the fistula was present between the anterior chamber and the sclera. The scleral tear repair was done. So on follow-up, post-op 1 month, the vision improved to 6/6, pressure was 16 mm of mercury, and on fundus examination, we couldn't find any disc margin edema or chorioretinal folds. So what was unique in my case? Traumatic anterior chamber fistula masquerading as a bleb in this case was an unusual sequelae of a penetrating ocular trauma. Appearance of bleb-like lesion is absence of previous surgery led to initial diagnostic confusion. Cases like this may be overlooked as post-traumatic scarring or self-sealed perforation, delaying critical intervention. The metallic foreign body can remain relatively inert for a long period without causing devastating infection, so we should rule out. And managing AC fistula requires a balance between preventing leak and maintaining ocular integrity, especially in the pediatric cases. So coming to the take-home message, we should advise all the B-scan, anterior segment OCT, and CT MRI. Early recognition and intervention are essential to prevent long-term visual impairment. Thank you. Yes, sir. CDL was negative in this case. Yeah. Intraoperatively also it was negative.
Apologies. Do you really need to inject the dye in the anterior chamber? If you stain it with CDL, you'll see the leak.
But if we remove the peritomy, then it was seen. Like conjunctiva was present over it. So after peritomy, the leak was present, obviously.
Yeah.
Thank you, sir.